Let's talk on an interesting topic of egg freezing or oocyte cryopreservation in patients with endometriosis and looking at the current evidence. What we do know is that oocyte cryopreservation has increasingly been considered for fertility preservation with endometriosis, a condition which is known to have a negative impact on ovarian reserve as well as on fertility. However, the effectiveness, optimal timing, and the outcomes of oocyte freezing in this population remains uncertain due to limited data and the variety of data that's present. So this was a systematic analysis which looked at 10 observational studies. There were no randomized controlled studies done, encompassing over 1,100 women with endometriosis who underwent oocyte cryopreservation using the vitrification technique. Both of these were retrospective studies. Women were aged between 29 years and 35 years. A majority had endometriomas, which are ovarian cysts of endometriosis, with some it included deep endometriosis and superficial peritoneal endometriosis. A significant proportion of them had a history of ovarian surgery known to further reduce ovarian reserves. What were the outcomes? The main outcomes were number of eggs oocytes were decreased with increasing age and with prior surgery. Younger women where surgery was not done had higher yields. The type, laterality, or size of endometrioma did not generally affect the yield unless you had a large or bilateral cyst. Post-surgery may further reduce oocyte number. Women with endometriosis had lower yields than the infertile controls without endometriosis. If you look at the number of mature eggs, oocyte trends mirror total oocyte yield. Some studies found no age effect, likely due to the younger cohort of patients. Differences between endometriosis and control were less clear, mainly for the metaphase 2 sites due to small sample sizes. So if you have a look at mainly the quality of eggs, that data was much lower. If you look at oocyte maturation, it ranged between 58 and 79%. Again, not significantly affected by previous surgery, but unilateral cysts may have slightly higher rates. Number of preserved closely matched with metaphase 2, lower numbers in women again with endometriosis compared to the controls. With how the eggs would survive, highly variable, and again, we still don't have very good data on it. The cumulative live birth rates, only 2 studies have been done, which found that live birth rates per women with thawed oocytes were around 46.4%. It was higher under the age of 35 and those without prior surgery. In young endometriosis patients, it was lower than age-matched undergoing elective, but this disappeared over the age of 35. In this study, achieving a high live birth rates required more than 20 or eggs, which is quite difficult to achieve in women who have endometriosis and especially in older age. Recent evidence suggests that endometriosis primarily affects the number of eggs, not their quality or the chance of having a live birth from each egg. Who are the best candidates for oocyte freezing? Young women with endometriosis, especially those without prior surgery, are most likely to benefit from egg freezing due to higher egg numbers. Oocyte freezing should ideally be performed before surgical intervention, as surgery further reduces ovarian reserve and oocyte indications. There's no consensus on which subgroup of endometriosis patients should be routinely offered at freezing, and guidelines are ambiguous. It's important to remember that most women do not return to use their eggs, but considering that the egg numbers as well as age has a negative impact, freezing eggs in endometriosis makes sense. The quality of this evidence is limited due to the observational size, and also the strength of the study is diminished because there were no randomized controlled trials.